Welcome to Wellness Fixes the Pod, a by Maven media production, where we believe you deserve real education from real experts delivered in a way you can actually use. I'm Dr. Kelsy Vick, your board-certified orthopedic doctor of physical therapy, and this podcast was built for the girl who is done feeling overwhelmed and frustrated by conflicting health noise and is ready for something she can actually trust. Every week, we have honest, science-backed conversations about your health, your hormones, your brain, your body, and everything in between. No fluff, no fear-mongering, just the truth. Because understanding your body is the most powerful thing you can do for yourself. A table full of experts built for the curious girl who wants the truth. So welcome. Your seat is waiting for you. Ozempic and fertility. Two words that I did not expect to go together this month, but here we are. PMOS is a complex multi-system condition involving the metabolic system, the endocrine system, and the ovaries. It is not just a reproductive issue. PMOS is not a primary fertility problem. It's a metabolic and hormonal problem that can sometimes manifest as a fertility issue. It's not that semaglutide is directly boosting fertility, but it's helping to treat that metabolic root cause that was disrupting fertility in the first place. In both men and women, the research is pointing to the same underlying truth. Obesity and metabolic dysfunction are major underlying, well-established disruptors of reproductive hormone signaling. Ozempic and fertility. Two words that I did not expect to go together this month, but here we are. A major endocrine conference just presented some very interesting early data. Let's break it down without the hype. Welcome back to Wellness Fixes the Pod. I'm your host, Dr. Kelsy Vick, a board-certified orthopedic doctor of physical therapy and a pelvic floor physical therapist. And ENDO 2026 just wrapped up at the time I'm filming this episode. We are still doing our wedding prep series, so this will come out as soon after that as possible. But the ENDO 2026 conference just wrapped up in Chicago, which is the Endocrine Society's big annual conference. And one of the most talked about presentations was on semaglutide and reproductive health. Semaglutide is the active component in Ozempic and Wegovy, a GLP-1 medication initially designed for diabetes, but now getting studied to be utilized in a wide range of other health conditions. We've heard it more recently and way more trending in the realm of weight loss, but I thought this presentation on its use in reproductive health, especially reproductive health for women with PCOS, PMOS, which if you missed that episode, PCOS got a rebrand to PMOS. So I will try and use that PMOS terminology throughout this episode, but just know if you have PCOS, you have PMOS now. They're doing this name change. It's going to take a while to be fully adopted, but PCOS is now PMOS. So do not get confused if you hear me say PMOS throughout this episode. So this is preliminary early stage research, not necessarily a green light that this is how clinical practice should be. This is how all research goes, where there's initial studies that start to validate different hypotheses and then future studies to test and work on different controls and fine tune and see which demographics it applies to. So we are in the early stage of all of this, but it's truly interesting research on the use of semaglutide for reproductive health. So as a quick refresher, what is PMOS? PMOS is the new term for PCOS. It is polyendocrine metabolic ovarian syndrome rather than the previous polycystic ovarian syndrome. I'll leave the link to our full episode that we just recently did below, but as a sort of quick overview on what PMOS actually is and the true root cause of some of the symptoms and of some of the challenges that people face with PMOS. PMOS is a complex multi-system condition involving the metabolic system, the endocrine system, and the ovaries. It is not just a reproductive issue, and it does not have to include cysts. There are actually never cysts at all. They were just arrested follicles at that stage in their development that looked like cysts, but cysts were never part of the equation, which is why, part of the reason why PCOS had a rebrand to PMOS, or polyendocrine metabolic ovarian syndrome. The metabolic piece is exactly why the semaglutide and fertility conversation is so important. PMOS is not a primary fertility problem. It's a metabolic and hormonal problem that can sometimes manifest as a fertility issue. which is precisely the way and the mechanism behind why semaglutide might actually lead to improvement in reproductive health for these girls with PMOS, as semaglutide often targets the metabolic component of our bodies. PMOS affects about 170 million women worldwide, so this study is probably relevant to a wide majority of you. So researchers from the University of Colorado Anschutz looked at a subset of participants in something called the RESTORE trial, an ongoing study testing whether semaglutide or metformin can restore ovulation in adolescents and adults with PMOS and obesity. So the studied participants were between the ages of 12 to 35 who lost at least 10% of their body weight while on semaglutide. And again, this is an ongoing study, which is why that age range is so large, because the idea would be that you're tracking a lot of these women and girls that are part of the study as they move throughout different stages of their life and their hormonal journey throughout our lives. So here's what they found. Reproductive markers improved, and they improved earlier than the researchers expected. That's actually why this preliminary data got published now instead of waiting for the full trial to wrap up. In PMOS, there's a relative rise in androgens, those male hormones, alongside insulin resistance. That combination can stall egg development and disrupt ovulation. Without regular ovulation, conceiving becomes very difficult and unpredictable, which is how the metabolic and hormonal component of PMOS ties into the fertility component. Excess body fat also produces additional estrogen, further disrupting that hormonal balance, that hormonal song and dance needed for menstrual cycle regularity. Higher body weight can also affect egg quality and even the uterine lining itself, making implantation that much harder. So the logic behind the study was that if semaglutide helps with significant weight loss, and weight loss can help address the underlying insulin resistance and hormonal imbalance, ovulation may naturally improve as a downstream effect. It's not that semaglutide is directly boosting fertility, but it's helping to treat that metabolic root cause that was disrupting fertility in the first place. So before anyone with PMOS rushes to get a semaglutide prescription, remember this is early on. So let's chat about what the study actually does tell us and maybe some of the limitations. This is a preliminary analysis of a subset of a larger, still ongoing trial. It's not a completed peer-reviewed research study yet. So yes, this is still a small sample size, which is one of the limitations. The big question is we don't know whether or not these reproductive improvements are sustained long-term. That's one of the reasons the RESTORE trial is continuing to run, to see is this an acute improvement, or does the use of semaglutide to help women with PMOS have more of these long-term effects on their reproductive health? The researchers themselves frame this as weight loss and metabolic improvement driving the fertility benefit, not semaglutide having a direct effect on fertility itself. Semaglutide is not currently recommended during pregnancy, and there isn't enough safety data yet on its usage during that preconception phase. If ovulation does improve and someone becomes more fertile on the medication, that raises real practical questions on timing, dosage, monitoring, and communication with a provider, which is why this conversation is definitely one to have with your provider, not just this do-it-yourself way of improving your fertility. This is promising. Mechanistically, it makes sense, early stage data, and not an official recommended prescription or clinical treatment. But I thought it was a super cool study to dive into, especially since the researchers themselves felt like this research was worthy enough to be presented at this new phase rather than waiting until the full study and the full trial was over. I love that this is this unselfish act for them to say, this is what we're finding. If anyone else has this interest and wants to study or sees this in their own clinical practice, this is one of the things that we're finding and might be able to help these women with PMOS with some of the fertility challenges that they have and some of these fertility fears that they have. I also think this is one of the primary examples on why PCOS actually needed this rebrand to PMOS. We talked about how semaglutide affects the metabolic system in our bodies. If PCOS was still viewed as polycystic ovarian syndrome, there's a lot of people who wouldn't understand that the metabolic component is one of the parts that underlies some of the fertility challenges of PMOS. So I think this is another example of the positive benefit that is going to come to girls with PMOS because of the name change. So let's talk about the other side of the conference and what they found in men. For years, there has been this lingering worry that some of these medications might affect male fertility, but the new data says the opposite. A separate research team from University Hospitals Coventry and Warwickshire and Warwick Medical School in the UK reviewed the randomized controlled trials specifically looking at GLP-1 drugs and male reproductive health. So men between the ages of 18 and 65 were studied comparing GLP-1 medications like semaglutide and liraglutide against placebo or alternative treatments. What they found, there was no evidence of negative effects on testosterone, reproductive hormones, sexual function, or sperm quality. A 24-week semaglutide trial actually showed improved sperm morphology, meaning healthier shaped sperm and improved cholesterol levels while keeping hormone levels stable. A separate 16-week liraglutide trial found increased testosterone and related reproductive hormones in men with obesity-related low testosterone. Notably, the overall health outcome in these men were better than what's typically seen with testosterone replacement therapy alone. So why does this matter for us on this female-specific podcast? Obesity-related low testosterone is incredibly common and fits into the other side of the equation when trying to conceive. We've done a male fertility episode, which is why I wanted to include this study that was also presented at the ENDO 2026 conference. So obesity-related low testosterone is very common and often treated with testosterone replacement therapy, which doesn't address the underlying metabolic cause and can actually suppress natural sperm production in some cases. This research suggests that treating the obesity itself, that metabolic component, rather than just replacing testosterone, may be the smarter long-term approach for both hormone health and fertility preservation. So the fear that some of these medications might negatively impact male fertility seems to be unfounded, especially with this newer data, and may actually help improve fertility compared to some of the typical current treatment recommendations. And if you're thinking, okay, so semaglutide affecting the metabolic component can also help male fertility, sounds very similar to semaglutide helping the metabolic and weight loss component for females to also help our fertility, you're noticing a little bit of a pattern and a little bit of a connection there. In both men and women, the research is pointing to the same underlying truth. Obesity and metabolic dysfunction are major underlying, well-established disruptors of reproductive hormone signaling. In women, this can look like disrupted ovulation, hormone imbalance, and impaired egg quality. In men, this can look like low testosterone, functional hypogonadism, and impaired sperm quality. So both of these studies show that rather than treating the reproductive symptoms in isolation, like doing fertility treatments in women and testosterone replacement therapy in men, addressing the root metabolic dysfunction first may produce better and more sustainable reproductive outcomes. So much of female and male hormonal health is downstream of metabolic health. Insulin resistance, chronic inflammation, and exercise adiposity don't just affect how you feel day to day. They directly interfere with some of the hormonal systems that govern reproduction. So finally, the connection between our reproductive health and our metabolic health is getting the much needed attention that it deserves. This is genuinely exciting early stage research that I feel like not a lot of people will know about. So bring this up at your next dinner party conversation, weave this in, because this is that early stage data that I feel like is going to become more mainstream as the studies progress and more studies are presented, understanding and researching the effects of metabolism and reproduction. And it's a great example why root cause thinking in medicine actually matters, rather than just putting a Band-Aid over something and treating what is at the surface. So if you have PMOS and are currently in your own fertility journey, these might be some studies that you bring to your healthcare provider to chat through and discuss. This is not a DIY thing. This is not me recommending it. This is truly early stage data. But if you have hit a wall when it comes to your own fertility journey and you happen to have PMOS or an underlying metabolic component to your fertility challenges, this might be very helpful in helping you to achieve the reproductive goal you have in mind, whether that is conception or just better understanding your own menstrual cycle and ovulatory patterns or regaining ovulation. So, a quick episode, but I hope you guys enjoyed it. I know I learned a lot when I was first presented with this information. I was like, okay, we have to talk about it because it's going to be very important for 170 million, but also that male side of the equation too. So, it reminds me of what we talked about with Dr. Emily back on in early in the year in January, February timeframe, where she was saying a lot of medications are presented as one way. So birth control medication presented for birth control, semaglutide and Ozempic and Wegovy presented as weight loss. But if we can look at it from a different lens and realize that all of these medications have systemic effects and full body effects, if we can use them in a positive way for another system within our body, let's open it up and decrease some of the fears surrounding this weight loss drug or this drug that has been previously prescribed for something else. So it's reminiscent of that conversation with Dr. Emily. So I hope you guys learned a lot. I know I did, and I will see you guys again on the next episode of Wellness Fixes the Pod.